Good morning, my name is Alexandra Lansky from Yale University. It's my pleasure to be here this morning with Dr. James McKenney from the National Clinical Research Foundation in Richmond, Virginia. Dr. McKenney, you're going to be discussing with us this morning monoclonal antibody to PCSK9 in patients with primary hypercholesterolemia. You're going to be presenting this as a late-breaking trial.
Yes.
Can you give us a little bit of background on your study, please?
Well, the background probably starts with understanding what PCSK9 is. It's a new word, but I think it's going to be invasive throughout all of our language pretty soon. We know something about LDL receptors, that they work in our behalf by removing cholesterol from the bloodstream. Giving a statin upregulates the LDL receptors. Giving a bile acid sequestrant and interfering with the recycling upgrades the LDL receptors. What we didn't know until very recently, that at the same time, there's an upgrade of this protein called PCSK9. And this protein's unique function is to bind to LDL receptors and lead to their degradation. So the more PCSK9 you have, the worse, because you can't remove the cholesterol as well. And there's been some diagnosis of familial hypercholesterolemia, but turned out to simply be too much PCSK9 in the population. So my drug that I'm presenting here is a monoclonal antibody that binds to PCSK9, holds it aside, and allows all the extra LDL receptors to do their job. And it's pretty remarkable, the effect.
And is there a way to measure PCSK9?
It is in the research lab, and I suspect it's going to be available commercially because it just makes sense.
So tell us a little bit about your trial, the trial design, and maybe some of the key features of the results.
Okay, so we think that this is a statin plus error, so we did a study that, this is a phase 2A, by the way, dose and regimen finding. So we took patients who were already being treated and made sure that they were on a atorvastatin 10, 20, or 40 milligrams. If they weren't, we washed them out and put them on that. So everybody started on the same regimen of a statin. Everyone had to have an LDL of 100 or greater and meet other sort of typical criteria for this sort of thing. We ended up randomizing 183 patients into one of 6 groups to make it nice and simple, right? One of which was placebo. 3 of which were every 2-week subcutaneous injections of our drug. Our drug is affectionately known as SAR 236553 for Sanofi. Regeneron, it's REGN 727. It'll have a name pretty soon, but that's what we're talking about. And so we looked at 50 milligrams every 2 weeks, 100 milligrams, and 150, and we saw in that a 40, 66, and a 72% reduction. Now, mind you, that's on top of the statin, which would have been predicted to already reduce LDL 40 to 50%. So everybody started off, by the way, with a baseline LDL of around 130, 127, that neighborhood. The other 2 groups were every 4-week dosing of 200 and 300 milligrams, and we found that at the end of 2 weeks after that dosing, we had the same kind of remarkable drop in LDL. But over the intervening 2 weeks, there was loss. So our antibody was wearing out and losing its efficacy. So it's clear on top of a statin that every 2 weeks is going to be the dosing interval for us.
So it's a drug that is given subcutaneously?
Subcutaneously. Yeah, okay. It's a protein.
Yeah, okay.
A monoclonal antibody, and yeah, it has to be given parenterally.
Right, and the concept here is that it has to be given synergistically with a statin, and so it's the combination that really is effective. It is.
That's how it's being tested today.
Yeah.
But this past week, Dr. Stein and his co-authors published a phase 1 results of the same product in New England Journal of Medicine, in which they also reported this drug's efficacy on nothing, just diet, and it produced the same kind of reductions in patients not on a statin. But from the FDA point of view, this is going to be a statin base, I think,
right.
at least to start with, and you have to add on top and show that you're efficacious.
And any glimpses into any kind of side effects from the
Sure,
from the
we
agent?
of course were quite diligent in looking for that. But if you look across all 6 groups, the complaints were similar, and the frequency was similar, and the frequency was relatively low. We had 6 people out of 183 withdraw because of side effects. None of them the same, and all of them were relatively pedestrian. Headaches, nausea, the injection site hurt. We looked specifically at liver and muscle because of the statin side effects, and we had no transaminases over 3 on any patient at any visit through the entire study. We looked for CKs greater than 10 times the upper limit of normal. We saw nothing in any patient over the whole study. We asked about muscle symptoms. 1 or 2 people sporadically had some symptoms that went away. So it doesn't look like we have any additivity, which is really a good news.
So this is very exciting.
It is very exciting. I mean,
yeah.
just to think about the number of people in our country in your practice every day,
absolutely,
who you just can't get but so far with
right.
current treatments, even if they're totally compliant. And yet you may be having multiple events going on in their life. They may be familial dyslipidemic patients that you just cannot get down but so
right.
far. You have people that can't tolerate, so now you have, or you may have, if we get to the end of the road, an agent that will solve that problem.
Right.
By the way, there was an LTAP2 presented by Dr. Waters in Circulation, which told us that of the very high-risk patients, only 30% get to goal of less than 70.
That's right.
In this study, one of our doses, the 150 milligram every 2-week dose, achieved that in 100% of patients.
That's pretty remarkable.
The mean LDL in that population was 35, by the way.
So what are the plans for next steps? I'm sure you're going into phase 3 trials. And,
well, I'm the investigator, so
yeah,
they'll tell me.
Yeah,
but
yeah.
surely, I know that there's going to be a phase 3 2B,
yeah.
just to make sure that we've selected the right dose, and that's going to continue to work the same way. And already phase 3 studies have been designed and are ready to start. And outcome studies are being designed, because that's going to have to happen.
Absolutely.
We have to be sure that this extra step is going to help people, not just lower LDL. So all of that's in the pipeline.
In the pipeline.
Yes.
Well, thank you. I want to thank you very much, Dr. McKenney, for a very nice interview, very intriguing study, and I think a lot of promise with this new compound. So thank you so much.
Me too. Thank you.
And that concludes our interview. Thank you so much.